Hi, everyone. My name is Dr. Laurie Slovarp. I am a speech language pathologist and a professor at the University of Montana. I research refractory chronic cough.
And I'm Reid Moorsmith. I'm the Chief Product Officer of Hyfe. Been with Hyfe since shortly after founding, and I'm an anthropologist by training and delighted to be participating in this conversation today. So can we start off, Laurie, by you telling us a little bit more about how you got involved in chronic cough in the first place?
Yeah, as a speech pathologist, I started treating this condition many, many years ago, but didn't really understand that much about, why our treatment worked or even what we call the pathophysiology behind why patients were coughing so much. But as I progressed in my research career, and as an academician at a university, I started researching it and became very, very interested in the neurology behind refractory chronic cough. And so that's what got me interested in it. And it's been really, really rewarding just helping patients. Most of the patients that come see us in the clinic have been coughing for a very, very long time, and they've seen multiple physicians, had lots of tests and treatments. And we are often the end of that road and provide a treatment that is very effective for patients. And it's just extremely rewarding to be able to provide that help for patients.
Can I ask how cough treatment became part of speech language pathology, since it's not in the name?
Yeah, that's a very good question. The first thing I'll say is that a lot of speech language pathology within our field are things that don't have anything to do with speech. And most people don't realize that. So, like cognitive disorders, like following brain injury, doesn't necessarily have anything to do with speech, and speech pathologists work with that. Voice conditions and upper airway conditions. So, there is a lot of what we do that's not speech, but it's still a very valid question. The question becomes, how did we get involved in cough? And there's two conditions that are very common in patients that have this cough condition. One of them is called inducible laryngeal obstruction. It used to be called vocal cord dysfunction. It's essentially the vocal folds want to close when they should be open, and it impacts breathing. And then there's this other one called muscle tension dysphonia that impacts how the voice is sounding. And these have been conditions that speech pathologists have treated for years, and they're considered what we call functional disorders. And that means the body is fully capable of acting as it should, but it's not. There's nothing actually wrong in the body and how it works. It's just the muscles aren't acting appropriately. And the only way to treat a functional condition is through behavioral treatment. There's no medication that will ever take care of that. And so, because speech pathologists were treating these other conditions that so commonly co-occurred with this cough condition, way back in the 90s, a patient came along, or a few patients came along, and said, I'm noticing that these breathing techniques you're giving me for my breathing condition is actually helping my cough. And essentially, the treatment has just evolved from there. So the speech pathologists back then that I wasn't practicing at that time started just experimenting. And we discovered that certain techniques to help them suppress their cough really actually worked. And it wasn't just that suppressing the cough was effective. The cough actually started going away. And so then it just evolved from there.
It's amazing. I didn't actually know it was patient-induced or patient-spurred, the first insights.
That's my understanding.
It's not quite the possibly apocryphal story of the guy in the ivory soap factory falling asleep while it's mixing in air or causing ivory to float, but has some of that happenstance to it. Very cool.
Yeah. So I'm curious, for your side of things, Reid, how did Hyfe get interested in the realm of cough that we treat as speech pathologists?
Yeah, so Hyfe was founded at the very start of the pandemic, a respiratory illness whose most obvious symptom was cough. And yet we had no way to measure it, and certainly no way to measure it in the real world, in the wild, as we say. And so very early on, Hyfe set out to crack that problem, to be able to monitor, count, quantify cough in real life using ubiquitous devices like smartphones or smartwatches. And we put a lot of effort into machine learning, labeled millions of coughs. Humans did that. And we developed models that do a very good job of telling the difference between ambient sounds, some sounds that are similar to cough, and coughs themselves. And our technology now enables us to count coughs in the wild, as we say, so in everyday life. And that has unlocked several different applications. But the first one was to ask ourselves, well, who needs this? Who would benefit from the ability to count cough longitudinally over time? And chronic cough bubbled to the surface right away. These are people who have, as you said, had cough as a big problem for a long time, who had not received the care they needed, and who needed to be able to track their cough the same way that we track body temperature with a thermometer or weight with a bathroom scale, using a device that travels with them instead of having to go into a lab for a test. And yeah, so that's how we started out working on chronic cough.
Very cool.
And one thing that I think most people don't know about, but is pretty fundamental to how you treat cough and how Hyfe and you are working together on the problem of chronic cough, is behavioral cough suppression therapy. So I'm wondering if you can teach us a bit about what are the basics of BCST, as it's called, and what's involved and how does it work?
So the first thing to understand is that this has been called many different things in the literature. So essentially, any behavioral treatment that is provided by a speech pathologist, sometimes it's called cough control therapy, sometimes it's called speech pathology for chronic cough. They're all essentially the same thing. And it's based on our understanding that what is going on in these patients is a hypersensitivity of the cough reflex. So essentially, things that should not be making someone cough are making them cough. And it's really a neurologic condition. And so, in a nutshell, what we do in this therapy is teach patients how to suppress their cough. And by doing that, they're essentially retraining their nervous system and primarily the brain to stop being overprotective. And that helps the cough go away.
And what are the elements of BCST?
So there's several elements. We give patients education about what's going on with them. A big part of that is understanding what cough hypersensitivity is, and also understanding that when there's no legitimate need to cough, it's completely safe to try to not cough, which we call cough suppression, to try to suppress your cough. And then we really give them several different techniques about how to suppress cough, because it's not easy. And a lot of patients will come in and they've all tried to suppress their cough already because it's a major nuisance. But we give them a lot of different breathing and swallowing techniques that help them be more successful. And then there's a lot of education about how, by doing this over time, it helps desensitize the cough reflex, which has become overprotective. And then in some patients, they also need some help with some breathing techniques, and they might need some help with voice if they have that co-occurring muscle tension voice issue. But those are just as needed. The crux of BCST is education about what hypersensitivity is, and then techniques about suppression, and making sure patients understand that in order to retrain the nervous system, they have to be very, very consistent with their attempts to suppress. They don't have to be perfect. No one's perfect. You can't suppress, off the bat. But by trying to suppress and giving and practicing at it, it gets better. And then it's just a process where the nervous system starts to relearn to essentially go back to normal.
Is it difficult for patients to tell the difference between protective coughs, necessary coughs, and coughs that can or should be suppressed?
Typically not. The biggest thing that we describe to patients is that a protective cough, you will know it's necessary if either there's something that you can actually pretty easily cough up. So if you're sick, if you have chronic postnasal drip issues where you have a lot of mucus, and within a couple coughs, that mucus comes up, that's not a cough that we want to suppress. And then the other thing is if you're in an environment where it's clearly dangerous, like there's really, really heavy smoke or chemical smells or something. But usually that's not the case for these patients. The vast majority of patients, their cough is primarily dry or completely dry. They cough and cough and cough and nothing comes up. So generally speaking, we just explain that to patients and they can pretty easily tell the difference. We even have some patients who have both kind of a productive cough for whatever reason, and then this dry cough, and they can tell the difference pretty easily. And it's usually the dry cough that's problematic because it often leads to severe coughing fits that are uncontrollable.
I'm interested in whether, in addition to refractory chronic cough, this kind of cough that is primarily or overwhelmingly a dry cough, one that isn't necessary physiologically, are there any illnesses that typically combine both necessary coughs, coughs that the body needs to clear the airway, and this kind of dry cough where they're combined?
Yeah, there's actually several. And in fact, the more we learn about cough hypersensitivity, the more we discover that these typically pulmonary conditions, pulmonary diseases like COPD or chronic emphysema, even asthma, we know these conditions commonly come with a cough. And in studies that actually look at cough sensitivity, because everyone has a cough sensitivity, because we all need to have a cough reflex to protect the lungs. And that actually can be tested. And in the studies that test that, even in people with pulmonary disease, most of them do have hypersensitivity. And so they will report, and I've worked with several patients with COPD, they will report they have this wet cough, and it's predominantly bad in the morning. And then they also have a dry cough, and it's the dry cough that leads to bad coughing fits. And they can generally easily tell the difference between the two.
So, yeah, I also was reading a paper recently about how treatment for lung cancer often produces cough that is separate from the cough that the tumors in the lungs are producing. And there may be some element of cough hypersensitivity or an induced cough that needs treatment that is separate from the cancer treatment itself. Have you read about that or heard about that?
Yeah, that the research as far as like doing what we do for patients in the realm of patients with lung cancer, that research is really in its infancy. But there is some data that shows that we can help improve quality of life in these patients. And that is one thing I should say is in a patient who has a pulmonary disease, the treatment is not as I hate to use I tend to not like to use the word curable. I tend to say we get patients into remission that have standard cough hypersensitivity. And the reason I say that is because when they get sick again, like an upper respiratory infection, the hypersensitivity will tend to come back. But so we tend to not be able to put patients with like COPD or lung cancer or something into remission where they won't have a cough anymore. But the techniques that we teach them about how to control their cough can be really, really helpful from a quality of life standpoint because these patients tend to uh, isolate themselves because having a severe coughing fit can be very disruptive, especially post COVID. We tend to call it there's a higher social penalty for coughing. And also it can scare people. You know, there's been people, I've seen a lot of patients that are in a grocery store and they have a major coughing fit and people think maybe they need to call an ambulance for them. You know, so if you can even just control that and prevent those severe coughing fits, it really helps quality of life. So it'll be really interesting to see over the next decade or so how far we can take that type of therapy, this type of therapy in, say, patients that have lung cancer. Because we don't want to be suppressing their cough if they have, you know, copious amounts of mucus in their lungs that they need to get out or blood. You know, that's not a cough we ever want to suppress.
Another thing I'd love to learn a bit more about is behavioral medicine itself. So when we typically think about somebody getting sick, the first response in Western medicine anyway is there a drug for that? Is there a medicine for that? And yet there are fair few conditions that are treated with behavioral medicine. Can you talk about any others that are similar to or analogous to or cousins of behavioral cough suppression therapy?
Yeah, that's such a good question and one of my favorites to answer. So, central to this of what we're doing with behavioral cough suppression therapy and cough hypersensitivity, central to this is what we call interoception. And interoception is the word we use to describe how our brains interpret sensations coming from the inside of the body. And as I tell my patients, the only reason you feel anything is because you have a brain. Your brain receives information from your body and then tells you how to feel about it, if to feel it at all, how to interpret it. And interoception can really vary and it can fluctuate depending on what experiences you've actually been through. So there's two analogous conditions that come to mind. One is chronic pain, and we know a lot of the similar brain areas in this condition we see at patients that have chronic pain. And pain in general is a nice analogy to interoception because everybody knows people that have different pain tolerances. And part of that is because of the surrounding events that happened that maybe started their pain. I often think of the really tough individual who's worked in a like a farmer or somebody that's worked in these environments where they kind of don't have time to deal with pain, and so they keep going. And it may be a stereotype, but these patients tend to have a pretty high pain tolerance. But the other one that's really interesting, and I think surprisingly even more analogous to cough hypersensitivity, is overactive bladder. And so what we're talking about here in patients is patients who don't actually have a bladder problem. They just have overactive bladder. And it is your brain that tells you when you need to go to the bathroom. It's monitoring what's going on in your bladder. So patients that have overactive bladder I should say, the gold standard treatment for overactive bladder is behavioral treatment. And interestingly, a lot of the same things they do in that therapy is similar in concept to what we do in behavioral cough suppression therapy, because it's primarily teaching a patient to not let themselves go when they feel like the urge to void and making themselves wait a reasonable amount of time. And then over time, that frequent urge to void starts to go away and it goes back to normal. What's really interesting is the science is a bit ahead in that area than what we know in this condition, because they've done brain scanning experiments before and after behavioral therapy for overactive bladder. And and then also studies that look at bladder functioning, and the bladder function didn't change, but some areas of the brain changed. And those areas overlap in the same areas that we know are involved in cough hypersensitivity. But nobody has done a post-treatment study. We're working on that, and hopefully within the next 5 years, we're going to have that data where we're going to actually look at brain MRI scans before and after behavioral therapy so we can see what's changing. And I think it's going to look very similar to that research on overactive bladder.
Super fascinating.
Hmm.
So that's looking forward to physiological evidence of what's changing as a result of BCST. What do we know about what changes in terms of symptom change, urge to cough change? Where's the evidence base for BCST now?
Yeah, the evidence is really strong. Like, this therapy does not get the credence it deserves in a lot of regards. When we look at other research in the realm of treatment for this condition, BCST, it has more efficacy than anything. And so there are 3 randomized controlled trials that support this treatment, and well over 10 other papers that have been published, varying from single cohort studies to retrospective reviews. And really, the pinnacle of efficacy that we look for when it comes to interventional studies is meta analysis. And what they do in a meta analysis is they take data from a bunch of different studies and analyze it together. There is a meta analysis that has been done on our therapy, and it also confirms the efficacy. So there's really strong efficacy that this therapy works. And the thing that I always want to stress in these types of conversations, because I think there's a big misunderstanding that what we're doing is just helping patients deal with their condition. And sometimes in the case of, like I was saying before, COPD patients or like lung cancer patients, that might be the case, but that's not the vast majority of the patients that we treat. Most of our patients have just refractory chronic cough, which is pretty much just straight up cough hypersensitivity. And in about 50% of those patients, their cough goes away. And so that's where I say they go into remission. They're not needing to suppress their cough anymore. They don't have a cough anymore. And even though many of these patients in these studies haven't had their cough sensitivity tested, we know their sensitivity has changed because they come into therapy telling us all these different things of making them cough. Things like talking and laughing and cold air and certain odors. And they end therapy, and those things are no longer even giving them the urge to cough. So they're just going on their normal day, and they're no longer feeling like they need to cough. So that's about 50% of patients. But over 80% of patients have a significant benefit. Even if they don't go into full remission, they have a significant reduction in the urge to cough. So we really are getting right at the heart of the problem. And that's what I think is so amazing about this therapy, is because any medication that you give a patient in this realm is going to just deal with the symptoms. And the patients are very likely going to have to stay on that medication forevermore because they really don't get rid of the hypersensitivity. They're just basically covering it up. Whereas this therapy directly targets the hypersensitivity.
And okay, we've talked a little bit about cough and lung cancer and cough and COPD, illnesses that have, in the case of lung cancer, eventually 100% mortality rates. So RCC and cough hypersensitivity, those are not killers. Why does it still matter so much that these people have a treatment that works?
Man, because the quality of life impacts for this condition are huge and very underappreciated. So a lot of people would be surprised to hear that the rates of depression in patients that have refractory chronic cough are higher than diseases like Parkinson's disease. So there is a very, very high rate of anxiety and depression and social isolation. A lot of these patients can't work. So not only are there these major psychosocial ramifications, there's huge cost to individuals and cost to our healthcare system, because patients generally will go to their primary care doctor and then they'll try some treatments. And then they might go to a pulmonologist and they'll do some testing and try some treatments. And they might end up at an ear, nose, and throat doctor. Same thing. Maybe a GI doctor. So they tend to see multiple specialists because the medical model for understanding cough has historically always been that cough is a symptom of an illness. You have to find out what the illness is and you have to treat the illness. That's still the case here, but no one knows that I shouldn't say no one, but in medical training, doctors in training are not taught about what cough hypersensitivity is. And cough hypersensitivity can come on for a variety of reasons. Maybe it came on because somebody had years and years of chronic reflux. But once you have hypersensitivity, treating the reflux or whatever it was that started it doesn't usually get rid of the hypersensitivity. So overall, this condition has huge psychosocial ramifications, huge healthcare costs, and that's why it should be appreciated.
The big picture of the number of people affected is one measure of why this needs to be addressed. A second one is zooming into the human scale. Can you tell us about one or two patients that you've treated that really highlights how effective and how important behavioral cough suppression therapy is and can be?
Yeah, there's a lot of patients that I could highlight, but one that comes to mind when I'm asked this question is a patient that I saw just a few years ago, and her cough started in the late 90s. So she was like 30 years of having a severe cough. And her cough started after a major chlorine chemical spill from a train derailment. in her town. And I actually didn't know about this. And I went back and researched it and read about it after she had told me. But, it was it was national news. It was very, very, in fact, I think I had read that it was along the lines of the train derailment in Ohio in the last few years. Anyways, we do know now that chemical exposure, especially a significant one like that, can basically elicit this cough hypersensitivity. So her cough was so bad that she would throw up almost every day from coughing. And she would go through stints. I mean, it's 30 years. She'd go through stints where she'd see doctors, try different treatments, all these tests, but then you give up, and you're like, I guess I'm just going to have to live with this. And then time would go by and, she would finally try again, thinking maybe something has been learned since then. So anyways, this patient comes in and she tells me her story, and I'm just so fascinated about how it started. I taught her about what cough hypersensitivity is. She said it was the first time she'd ever heard an explanation that made sense for her cough. And I taught her cough suppression techniques, just basically did the therapy. In 2 weeks, her cough was gone. And, she's in tears in my office at the end because she never thought that she would ever, she didn't even have the ability to hope for a cure at that point. She was just hoping to be able to get through life better. And then her cough goes away. So I wish I could say that was rare. Like, I see this all the time, which is why I'm so passionate about this area, because patients shouldn't have to wait this long to try a treatment that's inexpensive, completely safe. We just need to get this to more people.
Laurie, if BCST is so effective, why isn't it everywhere? Why doesn't every patient with a chronic cough know about it and try it? Why doesn't every doctor who treats patients with chronic cough recommend it? Why doesn't every doctor have it in their repertoire to suggest, hey, how about this treatment?
Yeah, such a good question. There's lots of reasons. One of the big reasons is lack of awareness. So as I was saying, in medical school, the concept of even cough hypersensitivity isn't taught standardly. So it's not something that, general practitioners are really aware of. And then there's also the issue of training, of access to speech pathologists that know how to do this. So this does require some special training. It's not really hard therapy to do, but you do have to really have a good understanding of what cough hypersensitivity is and what we're trying to achieve here with behavioral cough suppression therapy. Usually the therapists that do this treatment are voice specialists, and voice specialized speech language pathologists make up only about 3% of speech pathologists. So there's probably in the United States around 200 speech pathologists that treat this condition. Well, this condition probably, the estimates indicate that there's about 7 to 10 million people in the US that have it. So even if all the physicians were aware of this, there still wouldn't be enough speech pathologists to take care of it. So those are really the big ones, is lack of awareness and lack of access to the right speech pathologist, which is why I'm so excited about what we're doing together with Hyfe and trying to get this therapy into a digital therapeutic. So tell me what it takes, because this has been a really fun learning journey for me, because it's in the realm of something I never thought I'd be involved in. So tell me about what a digital therapeutic is and what Hyfe is doing about it.
First, I want to say it's been an incredibly exciting journey for me and for Hyfe, working with you and with your colleague, Jane Salois, as well. We've learned so much about cough hypersensitivity and RCC and behavioral cough suppression therapy. And we figured out at a certain point that one of the applications, which being able to monitor cough in the real world, as I was talking about before, one of the applications that it unlocks is the ability to treat people who have chronic cough if we can get them to use an app. And a digital therapeutic basically is an app or a digital format that plays the role of medicine in some way. And typically they're in mobile apps, in cell phones, and people interact with them the way they do with other apps where they're learning or practicing something. And there are some key elements that go into building a digital therapeutic or deciding whether a digital therapeutic is the right kind of tool for a condition. One, it has to have a symptom of some kind that's measurable, a biomarker if possible, and cough is that. So we can say 10 coughs or 5 coughs, or in the case of people with RCC, 1,000 coughs or 500 coughs, or maybe eventually 100 coughs. So it needs that. It needs to be some kind of behavioral modification. So if people change something, their condition will change. And there needs to be a way to digitize this so that patients can use the tool themselves. So there doesn't have to be a doctor or a therapist like you there all the time. And we figured out that, okay, chronic cough fits this. And then what else does being in a digital format allow us to do? It allows us to tailor the experience to each person, each patient, by being able to tell them, yeah, you've done these exercises, you've learned this material, you've practiced suppression techniques, and we can show what's happening with your cough rate or your cough count as a result. And in that way, build in a feedback loop that has measurement inside it. And this is super exciting. Not all treatments that have digital therapeutics have this advantage. You talked about chronic pain before, and pain, at least so far, is always a patient-reported scale. So it's subject to whether I have a boxer's pain threshold or maybe a lower one. So there's always a tricky bit of personalization there. But with cough, 1 cough and 0 coughs are 100% or infinite percent difference. And so we can tell the difference between someone who started off coughing a certain amount, has gone through therapy for, let's say, a week or for 2 weeks, has learned about suppression techniques, and we can feed them material that's appropriate to where they are in their journey of cough therapy. So that's super exciting. And the trick for us was figuring out, okay, how do we take a treatment that you and colleagues like you typically administer in 3, 4, 5 sessions in the office, seeing patients once a week, and turn that into the kind of experience that fits in an app where people have it in their pockets or nearby all the time. And so it changes the interactive dynamic rather than see a therapist, learn a bunch of stuff, practice, and come back in a week and then talk about progress and trouble spots to get more coaching. We can have that coaching built in all the time because we're there all the time. And that is a super exciting and big advantage of digital therapeutics, even though we're not replacing the human touch. We can simulate that, but we can never completely replace a therapist. So we have to use tricks of the trade and high engagement and rewards in order for patients to know that they're in good hands with the DTX.
Yeah, I'm so excited about it because there are things that it offers that we can't offer. I love that it's not just a replacement. It's not going to be for everyone, but there's going to be a lot of patients where this might be better than our one-to-one therapy, just like for what you said, that they're able to get the constant information and the constant the continual monitoring. So the possibilities with that are really huge, and I'm really excited about that. So given the fact that I'm not with your team all the time, all the engineers and everything that are involved, tell me, what does it take to turn this into a digital therapeutic, to build an app that works?
I mean, the first thing is we have to start with good subject matter. So we have to start with a treatment that works, and we have that in BCST. And we have to have the experts who guide us to make this decision and that decision about what to emphasize and how turning it into a digital tool retains as much of the original force and then builds on things, as you were saying, that only a digital tool can have. We have to have strong designers, which we have, who are skilled in building a digital experience that will feel comfortable and reassuring and trustworthy, and also interactive and maybe even at times fun. We need the engineers who can program this so that when it's coded up and it goes into the app stores and a person starts using it, they have a seamless experience. And we have to have measurement built in. And in a way, this is Hyfe's secret sauce, because we started out measuring cough and we have the ability, the yardstick built into the app to show people, here's how you're doing. And we believe that this is super important for people to feel confident, feel motivated, and have the stick-to-itiveness necessary to go through what they need to go through to learn how to suppress their cough, which, as you say, is not easy for most people and is super hard for some people.
Mm-hmm.
Other elements that are really required in order to go from this nice idea to a product that's on the market is a good regulatory strategy. So it's really necessary to start out with the idea of how is this going to get compared to what's already on the market? Is it going to get compared to a drug or pharmaceutical? Or if it's going to be considered something new, what is the comparator? And typically for behavioral interventions like this, that's standard of care. So that's not comparing it to a patient who has no treatment, but a patient who goes to a doctor and gets what is typically prescribed or recommended for a condition like chronic cough, like RCC, absent the digital therapeutics. So we're working on that comparison. One of the things that we need to start out hypothesizing is how big the effect size is. So are we planning to have a small, medium, large effect and quantifying that effect on, in our case, cough frequency, and then patient-reported outcomes like the urge to cough and like the psychosocial consequences in everyday life? And we're fortunate in that we're quite confident, based on the BCST literature and based on preliminary studies that we've done, that the effect size is going to be very large. So we may be able to rely on both objective measures and subjective measures to say, this is much better than anything that's out there for people with refractory chronic cough. Another thing that I think probably at the start of the journey we may have underemphasized slightly, but we have definitely caught up on, is the idea that this has to fit into clinical workflow. The graveyard of DTXs is littered with applications where there's a brilliant idea with lots of features, but they required healthcare providers, doctors, other therapists to jump through a million hoops in order to either prescribe it or oversee its use, or in some ways get patients access to this tool. And we've gone to great measures in our first partnership to bring this to market as a prescription digital therapeutic in Japan, to fit it into the existing clinic workflow. So that means taking things into account, for example, that many doctors have one computer with internet access that they use to access the public health records, and another computer that they use internally to the clinic to oversee patient care. So we've gone to a great lengths to make this easy to use, to build a healthcare provider portal, a doctor dashboard that doctors can scan quickly and get the essential knowledge they need. And then if they are more interested, they can plumb the depths and learn much more about each patient and all of the patients that they may have on the digital therapeutic. That's certainly fundamental to this working.
And so where do things currently stand in terms of bringing this to the market?
Yeah, so we've got kind of two prongs going on right now, and we're hoping there's a third very soon. So the first prong is to say we have a partnership with Kyorin Pharmaceuticals, a major Japanese pharmaceutical company. It's been around for over 100 years, to bring this prescription digital therapeutic to the market in Japan. So we have a fully localized Japanese version of the DTX, that is ready to go into the pivotal clinical trial, so the equivalent of a phase 3 trial, early in 2026. We're super excited about that and delighted with our partnership with Kyorin. The second prong is we have a wellness version of the DTX that's built into Hyfe's free cough monitoring app, Cough Pro. Anybody can access that if they go through the health screening and have the condition that they need to have, and we can ensure that they'll be safe in using it. And then we are in talks and actively seeking additional partnerships for other key markets to commercialize the digital therapeutic elsewhere outside Japan.
And so what happens after the app's approved and on the market in Japan or elsewhere? What's the process?
Yeah, so it does vary to a certain degree market by market because health systems have their own quirks and regulatory schemes. In Japan, it will be prescribed by doctors. It's considered to be adjunctive therapy in Japan, even though it is a standalone app, because that's the way the software as a medical device law is written in Japan. And patients will go into a doctor's office. There'll be the copayment that they're responsible for, but we expect that national health insurance will cover the bulk of the cost. What that looks like in each market will depend on how things unfold and what makes the most sense, given the regulatory scheme, given the partnership, given the business model. And these things are tailored to the conditions in each country.
Hmm. And so, what do we know at this point, like how regulators process or think about digital therapeutics right now? Because this is kind of a newer thing.
So digital therapeutics are generally regulated as medical devices, and that's the case in Japan. So the Japanese regulatory authority, PMDA, the equivalent of the US FDA, is regulating it under the software as a medical device law as a medical device. And this does vary to a certain degree, country by country. Different countries have gone further or less far to create specific conditions that facilitate digital therapeutics coming to the market. There's a law in front of the US Congress right now that we are perhaps naively optimistic may actually pass, even though not that many laws are passing in the US at the moment, that Japan and Germany and a few other countries have created distinct pathways for digital tools. And I would say there's maybe we've gone from a crawl to a slow walk, but we do definitely expect over the next few years that to be a fast walk, a jog, and then a run, because digital therapeutics have certain advantages. They have no side effects. They are, by definition, safer than most drugs because they can't be abused in the same way. Now, I'm not going to speak for every potential DTX that's out there, but certainly for BCST, chronic cough, our DTX has a very, very strong safety profile. And we think that that is going to hold a lot of sway with regulators, provided that we can reach the effectiveness bar that we're quite confident we will pass. Another reason that Hyfe got involved in trying to treat refractory chronic cough is the sheer numbers. So there are millions of people, as you said, up to 7 to 10 million people who have this condition, and most of whom just aren't getting the care that they need. They're not getting treated. And the idea that we can use what we already know about building apps, what we already know about counting cough, and we can package those together with your expertise to build something that could really transform cough care for millions of people. That's in the US, and up to 100 million people have this condition around the world, is inspiring, gets me out of bed every morning, and leads me to want to talk to anybody I can buttonhole to say, hey, there's something that's coming down the pike that's better than anything that's out there. Please give it a chance to see the light of day so that we can help those people get the treatment they need.
Yeah. Well, we're on the same page when it comes to that mission. I'm so grateful to just be partnering with Hyfe. because I wouldn't be able to do this without you guys as a team.
So, okay, everybody knows about cough. Everybody coughs. Most people at some point have a virus, cold, the flu, something that causes them to cough a lot. So we're all kind of intimately familiar with cough, especially parents with small kids who watch their kids suffer with cough. But what's something that people don't know about cough? Either something trivial or something important, but something that is not commonly known about cough.
I think most people don't know that cough, what we call sensitivity, which means how likely you are to cough at something, that fluctuates. It's not always the same. And even people that have RCC would agree with this because they'll say they have good days and bad days. And there's a lot we don't know why. But what we do know is that it's primarily regulated by the brain. And that can be changed by illness. If you're sick, your threshold for what's going to make you cough actually goes down. So it takes less of a stimulant to make you cough. So everyone can probably relate to if you have an upper respiratory infection or really bad cold and you go outside and it's cold, it makes you cough. That's because your threshold went down, which is the same to say that you have some cough hypersensitivity. And then when you get over your illness, that's supposed to go back to normal. But it's really the brain that regulates that. Your brain is always paying attention to what's in your airway to see if there's a threat. And when you are stuck in a hypersensitive state, like patients with RCC, the brain is interpreting things that are not a threat as a threat and making you cough.
Cool. That actually brings to mind the wives' tale about, or the folk belief, we should say, about cold causing us to get sick and to get colds. I wonder if it's actually the other way around, that we're a little bit sick and we don't realize it yet. And so our cough sensitivity threshold has gone down. We go outside and we cough more, then we get more sick and think, oh, the cold caused our illness, when in fact, the threshold caused us to cough and it was just a sign of our illness.
Yeah, interesting. I don't know. But I do think that the data seems to indicate that anything can contribute to cough hypersensitivity. In fact, although it hasn't been proven yet, I think that if I went around and just coughed a lot over and over again, I would probably change my thresholds potentially and make them stick in a hypersensitive state, which is essentially the opposite of what we do in BCST, is to try to get people to not cough because there's nothing threatening. And then that increases the threshold and reduces the hypersensitivity.
I'm I'm laughing because I think 5 years of simulated coughs to test our cough counters and just, play around with our apps as we've been building them, I think it might have actually caused me to cough more times in a typical day than I used to. I don't have cough hypersensitivity, but I think my kind of baseline number of coughs has gone from 5 to 15 to 20 to 40. And I wonder if it's because I spend too much time simulating coughs to get the counter to go from 1 to 2 or 13 to 14 in a demonstration for people on the street or in a pitch meeting or what have you.
Well, it's really interesting because there is, on the flip side of what we do, there are researchers in the last decade or so that have really been researching what they call cough skill training. And they're doing the exact opposite of what we do. It's been primarily in the realm of patients with Parkinson's disease who are known to have a low or a high threshold for coughing, meaning they're not coughing when they should be coughing. And when they do this cough seal training, they expose them to something that's a cough stimulant, and then they have them cough more than their body's even telling them to cough. And they find that it changes the cough sensitivity. So there is some research, some data to support this, and I'm just excited for the next decade for what we.
Yeah, super interesting. Uh, Speaking of the next decade, like, what are your hopes for people with chronic cough, people with RCC in particular, over the next 5 to 10 years?
Well, let's see. I would say that within the next 5 years, my hope is that cough hypersensitivity is recognized, by and large as a distinct disease so that it's no longer that cough is just considered a symptom of some other illness that we need to find, but people understand, doctors understand, the healthcare system understands. Cough hypersensitivity is a disease and it needs a different treatment. And I think that that will happen. I also am really hopeful that the DTX and the efforts that we're putting together are going to flourish and that it will be widely available. And then with that, that patients aren't going to be waiting for so long for an effective treatment. That our guidelines for these patients are going to evolve as the science evolves, as the availability of this treatment evolves, and that patients can go to the doctor, have the appropriate tests to rule out the serious things, and then that they'll be triaged to this type of a therapy. And because what we know is that when this therapy works, it's a long patient is 4 weeks. A lot of patients are really improved in 2 to 3 weeks. So my opinion is we need to try this therapy before a lot of other treatments and tests, because you might try this therapy in the amount of time it takes to get in for that invasive test or whatever. So my hope is that just how these patients are treated in the next 5 years is really changed. And in the next 10 years, and I think this is realistic, I think there's going to be just a lot fewer people with this condition if this evolves as we're really hoping and trying to make this happen. Because what we have seen in the clinic is that the sooner we get patients with this condition to BCST, the quicker their cough goes away. So when I see a patient who has only had their cough for 6 months, 9 months, anything less than a year, sadly, is short compared to most of the patients that we see. They've had it for 10 years mostly. So if I see somebody that's had it less than a year, it's not unusual that their cough is completely gone in a week. And I've had several patients that it's gone in a couple of days. So my hope is that within 10 years, this is pretty standard. And then we don't have people that are going around with a cough that have been coughing for years and years. It's just easily taken care of.
My hope and Hyfe's hope dovetails beautifully with that. It's been an incredible experience working alongside you and with Jane in developing this product, these products. And yeah, we think that not only do they hold the possibility of, bringing care to millions of people who need it, but also really changing the shape of how respiratory health is practiced in clinics and in doctors' offices around the country and the world.
I agree. It's just going to help with this launch pad for changing how a lot of conditions are treated, which is really, really exciting.
Awesome. Thanks, Laurie.
Thanks, Reid. It was great to talk to you.
Great talking to you.